An 89-year-old female slipped while walking towards the washroom. She sustained a right hip fracture and was taken inside the OT, where we did a preliminary examination under anesthesia. We gave traction, internal rotation and adduction. There was gross sagging of the distal fragment, so we lifted it up and attempted to reduce it. However, we planned ahead and went in for open reduction, where a bone hook was used to lever it and preliminarily obtained some alignment. There was opening up at the greater trochanter, so we had to balance the vectors by using an artery and a spike. A great metaphyseal void was noted at the junction of the neck and the diaphysis, and also the lesser trochanter was spiking anteriorly. Since it wasn't gross, we went ahead and fixed with 2 vice provisionally, over and above which we drilled it with the first reamer, over which we wanted to advance the rigid screw, but the proximal fragment was deflecting and rotating. So we had to improvise and use bone clamps and balance the vectorial forces so as to ensure that the lesser trochanter is in line with the shaft of the femur. Hardware complications ensued when we tried to slide the barrel onto the screw, but we templated and we got it right. Further on, the metadiaphysis void was impacted manually. The plate barrel offset was noted in lateral view and fixed likewise. Next, a derotation screw was added for giving added stability. So this is the post-operative radiograph showing the 85 mm screw with 135 degrees barrel and 85 mm cancellous screw with a washer. This was her mobilization on POD 1, and she had some difficulty but obtained it. On the next day, as you can see, she is able to hold it at that point. So do let us know what you think of our fixation. We'd be more than happy to take your remarks, comments and suggestions.